You're listening to the 40 Fit Radio podcast, dedicated to the 40-plus community. Join us as we discuss the truth about fitness and health using science, reason, and the experiences of our host and content experts. Welcome to the 40 Fit Nation. Hey, so welcome back to the 40 Fit Radio podcast, and welcome back to the 40 Fit Nation, guys. And today we're going to talk about pain neuroscience and how it relates to back pain specifically. This is kind of a series of episodes on back pain and training or fitness. The first episode we just covered last week, which was on the back and the anatomy and the general structure and usage of the back. And then today we're going over pain neuroscience. So let me just tell you up front, this could be an entire podcast talking about pain neuroscience. I am not an expert in this area. I'm a doctor of physical therapy and a strength coach. Trent's not an expert in this area. We have spent some time reading the literature. It is something that I use in my day in, day out medical practice, my physical therapy practice. And so it's something that's not foreign to me, but it's also something that is fairly new in its thought process. That there's this whole concept of how we think about pain and how people experience pain. So let's just say up front, pain is a symptom, not a sign. And what that means is that when you're a clinician, when you're a doctor or a PT or nurse or whatever, and you see a patient for an exam, you're looking at signs and symptoms. Symptoms are the things that the patient reports. It's mostly subjective. That subjective data could have objective data in it, like I went to go cough the other day and I wet on myself. I had incontinence. Well, that is a symptom saying that there could be a sign of incontinence, which is a positive sign for potential lumbar nerve root problems or sacral nerve root problems or some other problem. It could just be a weak bladder, But those are the kind of things that we look at. We look at signs and symptoms. So signs are what we can actually objectively measure and see in a clinical exam or in diagnostics or in some other laboratory setting. It could be blood work. That would be the sign of altered blood work. Again, symptoms are subjective. Pain fits into the subjective category. It fits in the category of things that it's really hard to measure. We've got things like the Ransford pain scale, the Borg pain scale. We've got RPE, rate of perceived exertion, which really doesn't relate to pain, but more stress.
RPP.
Yeah.
Rate of perceived pain.
Yeah. And
sometimes it feels like that.
Yeah. And that's absolutely. That's the analog pain scale. I mean, every time here's an interesting thing I'll tell you, it's just personal experience or professional experience. Whenever I have a patient coming in the office, I always ask him, what's your pain on a 0 to 10 scale? And I give him the measurement system first. I say 0 is no pain at all. You're at rest and you're in perfect harmony with the world. 10 is, I got to go to the hospital. This is the worst pain I've ever had. If you had a baby, this is worse than that. It's the worst pain in your life you could ever experience, and it's emergent pain that requires hospitalization. 5 is in the middle.
Yeah.
But I can't tell you how many patients, 6 and 7 would basically be strong, 3 and 4 would be minimal pain.
Yeah.
I can't tell you how many patients who will write on their analog pain scale first, Ransford pain scale, they'll write something like 9, and I'm having a conversation just like I am with you right now.
If you can talk, it's not more than a 7.
No, yeah, exactly. And so, I mean, and invariably the person that has the low pain tolerance is always the person that perceives that they have a high pain tolerance. It's so weird. They'll come in and say, man, I have a high pain tolerance. I have a crazy high pain tolerance. And then when you do an exam on them, you realize that they don't have a high pain tolerance at all. But that's their perception.
Right.
So pain has to be perceived. First, there is an organ that generates the pain. And that organ is an extremity or skin or some target organ.
The peripheral nervous system.
The peripheral nervous system, that's right. And there are receptors there, and there are small C fibers that transmit that pain. And it's a lot more complicated than that, but basically there's certain nerve fibers that are pain nerve fibers. And it goes up to your brain, and then your brain interprets that pain and how it's supposed to be felt. But it is felt.
Yeah.
So it is bathed by your whole human experience, your emotions, your intellect, your cognitive level, you're at a primal level to it, your thalamus. And so it is felt, and then you say to yourself, that feels like this, or that feels like that. And so pain is a symptom, and it's also a feeling. Now, it doesn't take away from the fact that pain's real.
Right.
Pain is real. So when I tell patients it's in your mind, I'm telling them that's where it's perceived.
Yeah, they're not necessarily making it up.
No.
All.
I mean, sometimes they do, but that's called malingering.
Right, yeah.
But we can tell that patient pretty quickly. But yeah, I mean, they're not making it up, but they are perceiving it. And so if they're perceiving it, then they are basically interpreting that.
Yeah. So if I can kind of, encapsulate that in very layman's terms, which by the way, you said I wasn't an expert in pain, but I have seen Rocky.
Oh yeah, man, rock and roll. Yeah.
What was it? Rocky 2? There was the Clubber Lang.
Yeah.
He's like,
yeah.
What's my prediction?
Yeah.
Pain.
Yeah, exactly. Yeah. You're right. I mean, the good thing about people like you who have transitioned their lives into a barbell training lifestyle too, or an exercise lifestyle, a training lifestyle, is that you develop a higher capacity for stress and pain and discomfort. Let's call that discomfort.
Absolutely.
Training discomfort. Pulling a heavy load or doing a heavy bench or something, it's uncomfortable.
Yeah. I wouldn't call it painful at all.
But it's uncomfortable.
But it is uncomfortable. And yeah, it does recalibrate your real pain.
Right.
Right. Yeah, putting yourself in discomfort. And we're definitely going to get into that later. But so if I could kind of quickly encapsulate what you've laid out is basically we've got this traditional model of pain, which is kind of a structural model whereby we've got some sort of stimuli that excites the peripheral nervous system that sends a pain message up to our brains that's then interpreted and sent back out, and localized as a feeling of a sensation of pain. But the new kind of emerging model of pain is much more complex than that, in that pain is mixed up with the emotions and the feelings and the previous experiences you've had. And in fact, that perception of pain that's mixed with prior experience can then generate new sensations of pain via a complex kind of network of behavioral changes, of actual structural changes, and other things we're going to get into here in a second.
Yeah,
we've basically gone from a very
rigid, more rigid model,
functional model, where it's kind of A explains B, a very causal model, to something that's a little bit more of an inner a web of causes and effects.
Yeah, I mean, as medical professionals, we always look for causalgia. We look for cause and effect. This occurred, so then this happened because of that. And sometimes that's good and sometimes that's bad, because sometimes it's multivariate. So there's a lot of things that are going on that we haven't considered. And that's kind of what we found out with pain. I will say that in the normal, so there's two things to look at here when you talk about pain neuroscience. And we're talking about back pain as it relates to back pain, but this could apply to any pain or injury in the human body.
Sure.
The normal response after injury or insult to the body would be there is a stimulus of the nociceptive, the painful fibers in the target area. It could be your foot. You could drop something on your foot. You could pull your back during a deadlift or a squat. You pull musculature. There is damage. There's actual damage in the musculature at that time, and that stimulates the painful nerve fibers. It then goes to your brain. You immediately feel that. Your body then says, heal the area. The body says, in a primary healing model, the body says, heal the area. If you treat it correctly, and if you're active, and if you do the things you're supposed to do. Now, let's say you have a complex fracture. The treatment for that is not movement. It is, if it's a complete break all the way through the bone, and it's a severe fracture that's got malalignment, and that's got to be set, and then that bone's got to go into an immobilization period for at least 4 to 8 weeks based on your age and based on which bone it is. And so the proper treatment for that is stillness, lack of movement.
Right.
But in most cases, motion's lotion. Movement is key. And so then the body heals itself and the pain goes away. But there has been an experience of that pain where that pain is not just a stimulus that disappears. You remember it. Your memory remembers it. It goes through a series of organs in your brain that are organs that we won't get into today because it's highly scientific and it's a bunch of minutia that you probably don't want to hear of as a listener. But the amygdala is involved, the limbic system, the frontal lobe, the thalamus, all these different areas are involved.
Yeah.
It creates a hormonal response. And
we should say that those mechanisms aren't fully understood either.
Right. No, and we don't have a full mapping of those areas yet. But what happens is it heals, it gets better, and you move on down the road. The second way to look at this would be this, and this occurs in about 25 to 30% of the human population. There's an injury. And there's a stimulus, like we said exactly before. Let's say you pulled your back during a heavy deadlift.
Yeah.
And then it heals, but for whatever reason, there's about 4 different things that occur now that set up almost a chronic pain loop, that set up a chronic pain scenario where even though the original insult is gone and the area has really been healed, there is still pain in your perception as a human being. That's a problem. And that's what we're going to address and talk about today. And the reason why we're talking about it is because when you talk about back pain specifically, there's a very high percentage of individuals. And when I say high, it's not high overall percentage-wise, but it's higher than other types of injuries where those individuals can become chronic pain patients or chronic pain individuals over time. And then there's a real problem in how they deal with life and everything else. And it limits their potential.
Right.
And so when we think about pain, we got to think about it in those 2 ways. Now, the second thing is here. The last thing would be here. There could be an insult to the body, and the body didn't heal it well. And there are scenarios where the body didn't heal it well, or there's an ongoing pathology. Let's say a knee that's bone on bone.
Okay.
There's no cartilage in the knee. The cartilage doesn't have nerve endings in it anyway, hardly. There's very avascular, very aneural. There's very little information or sensory information being sent back to the brain from the joint about cartilage injuries.
Sure.
Okay? But once the bone is exposed, the subchondral bone is exposed, then there are nerve endings in the bone. And now we're bone on bone, it's grinding. That's going to be an ongoing chronic pain, an ongoing pain cycle. And I don't care what you do, that patient's going to hurt.
Yeah.
Now, there are ways that you can mitigate that. You can put them on NSAIDs and you can give them pain medications. And pain medications are the worst thing for that patient, opiates. And that makes the pain worse and makes their pain perception and their ability to deal with it poorer.
Yeah.
And so it hypersensitizes the pain system, makes them feel more pain. What do you got to do with that patient? They need a knee replacement. And then they need to get back to the bar. They need to get back to working out. They need to get back to living an active life. And then hopefully you reestablish a normal pain loop again.
Right.
But so that's another scenario where we have to be very careful as coaches and as doctors of physical therapy and physicians that we don't just say, oh, well, they're a chronic pain patient. Well, no, they have ongoing pathology that's getting worse over time.
Yeah, and maybe that's a good place to say that, pain has an evolutionary purpose. Pain evolved as a mechanism for the body to protect itself. And so, in the case of somebody that does have that ongoing pathology, that is where pain is working correctly, as it was intended by evolution to help us protect ourselves, keep us from further damaging our bodies. The problem comes in when we're still experiencing pain, but we like you said before, we've either healed up or we don't have any existing pathology, and it's affecting our ability to do, our ability, to live quality life.
And what else could be occurring is there might be existing pathology, but the pathology is limited enough that the best way to treat it is to use it. And so it's going to hurt sometimes. So we'll just talk about that real quickly. Some of you guys know and some of you guys don't, but I had 4 back surgeries in a calendar year. 2.5 years ago, I had 4 separate major back surgeries. My final back surgery was I had an L4, L5 posterior lumbar interbody fusion. I have 4 lag screws and 2 rods in my back. And what do I do to treat it? Well, yesterday I pulled 465 for a lifetime PR,
Yeah.
So, I have back discomfort every single day when I wake up. My back is sore every single day. So I have a choice. And I always tell my patients this, and this is my classical statement in the clinic. You have a choice. You can be strong and less painful, or you can be weak and more painful. And it matches the literature. It matches, when you have patients that have ongoing problems. I have an ongoing back problem. It's just something I'm going to have to live with. I was cut on 4 times. I have a lot of scar tissue. But the best way to deal with that, and the arthritis that's there, is to infuse that area with blood, fuse that area with larger muscle bellies in a controlled environment using the right technique and taking care of my back so that over time it becomes more usable, it becomes more functional. But it doesn't take away from the fact that my back is going to hurt some, but it's manageable.
Right, right.
The flip side of that is someone who decides to give into that. And that's what we're talking about today.
Yeah.
And you know what? Get this, man, Trent. Chronic low back pain, in a global sense, is the leading chronic pain issue in the world today. Just chronic low back pain in itself.
Yeah. I mean, I think we all anecdotally know somebody or ourselves experience chronic low back pain. I saw some statistics from the NIH that was about 2% of American adults that report, and granted, this is self-reporting, so there's probably a higher number.
There's a lot more than that.
About 2% of adults that report regular opioid usage, half of those say it's directly because of chronic lower back pain. So there's a lot of implications here, right? And that's just opioid usage, right? Which is that's a whole nother rabbit hole we could go down. But yeah, it has some serious implications. So the more we can understand this, the better we're able to deal with it and live higher quality of life, which is what we're all about here.
Yeah, and I think the reason why we're having this episode is because we want our listening audience, if you're out there dealing with chronic low back pain, or you just recently injured your back in an exercise activity or while you're training, we're trying to right-size your thinking model to a scientific model, give you empirical data, give you factual information on how to move forward and not allow that to stop your training. That's the key. I had a client the other day. It was in our gym.
Yeah.
She pulled her upper back during the squat, so she decided she wasn't going to do anything else for the rest of the training session. Well, luckily, Coach was in the gym. And I looked at her and I kind of checked it out and I said, I think it's just a muscle pull. Let's move forward. And she's like, well, what do you want me to do? I said, I want you to squat. Well, this hurts. When I'm squatting this much weight, it hurts too much. I said, well, let's lighten the load a little bit. So we finished her working sets. Then she had to press. She said, I don't think I'm going to press today. It's hurting some. And I was like, no, we're going to press. We'll just lighten the load. So we pressed too. And she said, well, you know what? It's feeling better. What do you think I should do? You think I should deadlift? I said, yeah, let's deadlift. Think about how the upper back musculature are contracting in deadlift. I mean,
that's a thoracic extension.
Yeah. Right? I mean, there's a lot of load in the mid-scapular region. And so we deadlifted, and we deadlifted a normal load that day. We deadlifted the prescribed load. The next morning she woke up, she had no pain. And she will tell you with no doubt, 100% certainty, that normally she would have stopped her workout, gone home, and the next morning she would have woke up sore and with lower ability, with some disability, some impairment. But instead, we changed her mindset. We actively rehabbed at it. Now, there are some cases where you break a bone, you need to step away from the playfield.
Yeah, right, right.
You have a punctured lung or a busted spleen, you need to step away from the playfield. You tear
your bicep and it rolls up. And,
right, that's a problem.
That's problematic.
You're not going to train through that. So those are things that we got to be careful of too. And so we have to think about this with a didactic mindset, with an investigative mindset, and not just say train through the pain. I hate it when I hear that and I see that, and strength coaches are just blindly, everything you got to train through. Not necessarily. Most things, yes, but not everything.
Right. And of course, when we're talking about general health and not athletic, I think when you're an athlete at a certain level, the question becomes, can you go?
Right.
I'm stealing that from Dan John. He said he has a whole book about that. He said, can you go?
Right.
But that's a different question from, are you injured or hurt? Can I perform at the level I need to win this game or whatever?
You can play injured. You normally shouldn't play hurt.
Right.
Significantly hurt, but you can play injured.
Sure. Almost every athlete at a certain level does.
I mean,
all the time.
Yeah, absolutely.
But when we're talking about general health, we're not. This is a different thing. We're training for longevity, for quality of life. We're training so that we can do the things we love to do better and longer and all that good stuff.
That's right. So let's talk about. Okay, so let's rule this out first. Let's say that there's been a normal pain response. The person has had an injury or an insult to the body. Let's say it's that lumbar pull, the lumbar pull.
Right.
Or let's say it's a herniated disc.
Sure.
Bam. It's a herniated disc. And they have healed from that. They've been active. They've gotten back in the game. And yeah, they may have a little dysfunction from time to time, but they work through it and may move on down their life. That's the normal scenario. The second scenario would be that they don't move on. And this chronic pain loop sets up, and that's about 25 to 30% of the lumbar or the back injured population. So it's a fairly large number. Almost a third of the people will experience some type of chronic pain in their back in their lifetime. That are injured or that have back issues. So, we talked about last episode, and we'll reiterate that and reinforce that in this episode. You are not your MRI. You are not your CT scan. You are not your diagnostics, your bone scan. Now, those diagnostic tools are very important, but they have to match the clinical exam. So if someone comes into my office and they have no clinical findings, they're normal, but their MRI looks ferocious, it looks terrible. It gives me some thought for cause and pause on what I'm going to do with them. But ultimately, they're asymptomatic. And 80%, here's the interesting thing, as people age, the incidence of degeneration and pathological changes in the MRIs and CT scans increase exponentially as they age past the age of 30. But yet the majority, 80% of those individuals are asymptomatic.
Yeah.
They don't have a problem.
You mentioned that last episode that we have. It basically, you get to a certain age and almost every single person is going to show some sides of degenerated back.
Yeah, I got a blown disc. Okay, great. You and the rest of the population.
It's just it's a consequence of being an upright, bipedal human being. Yeah. And having to resist gravity for our lifetimes.
In fact, in most times, the degeneration is a normal process of aging. But we do know now, and we'll talk about in the next episode, that interventions and loads and training can actually slow some of that down, improve function. And that's the key. Absolutely. But let's say in this second scenario, they don't get better. And now they have this chronic pain loop. And that's what we're going to talk about right now. And that is, there's generally 4 different things that happen. And Trent, why don't you kind of give an overview, just a flyover on that?
Sure. Well, I like the deadlift example, right? We could substitute any activity that we're doing, but we'll use a deadlift since we like strength sports. We got somebody that comes in, they're warming up in their deadlift, they get to their work set, and the third rep, something popped in their back.
Bam!
Right, and it hurts.
Oh, my back!
Right. I blew an O-ring.
I slipped my disc.
Yeah, slipped a disc. So we've got that perception of pain acutely, right? We've got the nervous system is firing off, and like you said, in this example, we don't have a good coach like Coach D that says, "Hey, well, let's check it out. Let's keep moving."
4 weeks of rest,
right? Yeah, we take 4 weeks of rest. Wake up, and the next morning, it's sore, it's painful, it hurts to move, it hurts to bend. So then we start to create these maladaptive behaviors, right? So the perception of pain has caused oh man, every time I bend my back now it hurts.
So I'm not going to bend my back.
So I'm not going to bend my back anymore. So now we find ourselves, instead of normally bending our back into flexion to go tie our shoes or whatever, pick something off the floor, we stop doing that. The range of motion in our trunk reduces. And now we do that long enough, and we've got some comorbidities, as we'd call them, that crop up. Because we have not been using our back, it gets weaker. Right. And gone long enough, we can't use our back anymore because of the weakness, right? And that can cause long-term actual spinal changes, right?
Sure. Yeah, I mean, I think generally when we think about this whole chronic pain or pain neuroscience model, like Trent said, we're looking at 4 different areas. Number 1, there are actual central nervous system changes in your brain, where your body is remapping or reorganizing morphologically how it perceives pain. There's overactivity. There's what we would call hypersensitivity to pain signals now. Your body can perceive that, a little bit of a stimulus now is oversensitized. And you also bathe that in your frontal lobe and in the amygdala. You're actually bathing that through your emotions too. So think about it. I can tell you right now, when I have leg pain again, which I have every now and then, before I had my last lumbar surgery, I would get out of bed in the mornings and I would go to stand up, and the leg pain was so severe and lancinating that it felt like someone took a knife or a pickaxe and shoved it in the anterior shin of my right leg. It would start like in my posterior lateral thigh, and then just radiate down, and it would kind of stop right up above my knee, and then I would get this very sharp pain. It was severe. It was so severe that it eventually caused kind of a foot drop. And so once I stood up and I got upright and I got moving, I would get into the shower, and then I'd go coach a 5:30 a.m. CrossFit class, a picture of health, right? I couldn't show anything because I couldn't bend over, but it was so severe. And now when I have leg pain every now and then, I have to be very careful because I automatically begin to think, oh, is my back bad again? You know? And there's this emotional experience. There's this hormonal experience, this emotional experience that I have to say my back is bad again. And I can't go down that road. Now, it doesn't mean I don't listen to symptoms and I don't look for signs too. And I don't take care of my back, but it also means that I don't jump to the next conclusion. I don't say, oh, my back's broken again or my back's bad again.
That's what we would call catastrophization.
Yes,
right.
Exactly.
Catastrophizing, that experience of pain, right?
That's right.
And like you said, so this feeds. You can start to see how all these four things are so tightly interwoven because that anticipation of pain cause
anxiety
without your kind of clinical mindset tempering those experiences. You might then be be tempted to go back into those maladaptive behaviors, right? Stop using your legs, stop deadlifting, stop doing things that make it better.
Oh, I can't do those things anymore. And I will say this, there are some things that I have gotten smart with and I don't do anymore. And most of those things are more uncontrolled activities in the spine where I can't predict the forces as much. And some of those things were some of the CrossFit activities I was involved in. Like I don't do burpees anymore. Yeah. Because I can't, unless I do them really, really crazy strict, which is basically, I don't jump down on the ground and fall to the ground anymore. I basically will step down to the ground, do a strict push-up, stand back up, and it's very methodical,
Right.
But basically there's these central nervous system changes that happen first. And these are actual rewiring, remapping. The second thing, like Trent said, is you start to get behavioral cognitive changes. There's maladaptive behaviors, what we call in the clinical world, fear avoidance behaviors, where a great example would be this. Patients they become the identified patient. They'll say to you things like, I'm the back patient. Oh, I'm a back patient. No, you're not. You're John. You're John, whoever you are, John Doe, or Jane Doe. No, you're not the back patient. You're the patient. And you're not even the patient. You're the person that's experiencing a physical injury, and we can treat this. But you become the identified patient. I'll tell you right up front, that kind of became me for a while. I really struggled with that and not identifying myself as basically just a patient, but as the bad back patient. But so there's these maladaptive behaviors, fear avoidance. You stop doing things you normally would. You stop moving your spine the way you should. You avoid lifting things. And then what happens is you actually get these spinal changes where that's the third thing. And then you actually get altered motor control. You start firing those musculature in a maladaptive manner. You stop contracting your back the way you would normally when you bend over. And you have these compensation behaviors. You stop walking the same way. And then the last thing that can happen is when all three of these things are put together, it can actually cause other medical problems like insomnia. You start taking opiates or antidepressives. They give you Lyrica because they're trying to help you with your pain, and you get insomnia or inactivity, and then you gain weight, and then you get hypertension, and then you get metabolic syndrome, and you can see how there's these other comorbidities. All these things kind of tie together into chronic low back pain. What we think can happen here, though, is that with the right rehab model first and the right training model second, and sometimes the training model supersedes the rehab model. I hate to say that, but even in my clinical practice, we can get our listeners back to doing the things in life that they love to do, and either treat this once it occurs or avoid this altogether.
Right. Yeah, I think that's a really empowering thing about this is the brain rewired itself in the first place to get you into that chronic pain loop. It can be rewired
absolutely
to go back. The brain is plastic, and we can take advantage of that.
Yeah, and we basically call that, when we use exercise or training or intervention, whether it's in a clinical setting or it's in a gym setting, like we're sitting in the 40 Fit Radio podcast booth today, it basically is exposure without danger principle is what we call it.
Right.
We're going to expose the individual to a certain stressor or to a certain activity ensuring them that this is not going to danger them. We have to change their wiring and the way they think. We have to help them realize that I know it's a little uncomfortable doing this, but there's a greater good here.
Right.
There's a reason why we have to do this. You have to go through this cycle before you get stronger, before you're going to feel 100% better. But here's what I find, and this is almost 100% of the time, and I don't have a double-blind study to prove this myself, but this has been my experiential evidence treating patients in clinics for 28 years and also seeing them in the gym in a fitness environment. Almost 100% of the time, if they will believe in the process and if they will put forth effort, they will get better. And all differing varying levels of getting better. They might still have discomfort from time to time, and they might still have to modify some of their lifestyle based on damage to tissue, structural damage, or whatever else. Like there are some things, like I said, I just don't do anymore. I've gotten smart. I just don't do those things anymore. The risk is not worth the gain. And there's some other things that I've chosen to do because I believe in the science and I believe in the methodology behind them, and I don't think it puts me at undue risk.
Right.
For the rate of return. And so, but 100% of those individuals will do better. But so many of those people, a large percentage of those people, they just don't have enough faith or trust or hope to buy into the process. And what I want our listeners to do, if you're an athlete out there, if you're a lifter, if you're a CrossFit athlete, if you're a runner, if you're a swimmer, if you do triathlons, whatever you do, if you do yoga, whatever you do, and you're suffering back pain, and we could safely say that that's probably 80% of our listening population has had back pain in their lifetime.
Sure. I've had it.
That's right. And about 25 to 30% are dealing with chronic low back pain. So if you're listening to this podcast, you can improve your quality of lifestyle, but you got to believe in the system, and you have to be in the right system.
That's right. Yeah, I think that's something that gets overlooked. When we talk about this new model of pain or this emerging model of pain, it's sometimes referred to as the biopsychosocial model of pain. And we talked about the biology, we've talked about the psychology, but there's also the social part of it. And I think that plays a huge role. If you go to a gym that's serious about training, that approaches it in a logical manner, and you've got people that don't overreact when you've got a perception of pain, you've run into something, you pull your back, whatever it is, that makes a huge difference in your experience with this chronic pain loop that we're talking about. Surrounding yourself with the right type of people,
that's key.
The right mindset.
Totally key.
It's huge.
Yeah, I mean, when I have a patient come in and say they have a terrible MRI and their doctor told them to never lift 10 pounds again, I want to say to them, that doesn't matter to me.
Right.
I don't, but I want to say to them, that doesn't matter to me because I want to look at your clinical exam. What do you look like in my clinic? Your motor nerves are intact. Your peripheral nerves, your sensory nerves are intact. Your reflexes are normal. Your sensation is normal. You got a little bit of back pain and you have some back spasm. All right, let's treat that.
Right.
Let's treat that.
Yeah, I think of how cool it is. Someone like, one of our previous guests, Dr. Sullivan.
Yeah.
Sully's got his gym, Gray Steel, and he more or less specializes in an older population, lifters in their 60s, 70s,
all
80s.
those people have positive
They've all got
MRIs.
Something, right?
Yeah.
But they show up, they're serious, they do the work, and they do what they can, right? They train hard, and I imagine the training environment there, that's got to be super cool.
Yeah, I mean, you can be stronger and more functional and more able and less painful, or you can be weaker and less functional and less able and more painful.
That's right.
It's really good science. And so, when we talk about pain too, we haven't really delved into this, and we won't get into this very deep at all today, just because there's so much information here. But there are different types of pain generators. There's chemical pain, there's mechanical pain, structural pain, and there's all these. And then there's this, the psychological aspect of pain. But in general, when the body's doing its job, and it's healing areas, and there's a primary healing process taking place, then the pain should be diminished and go away or be very minimal. And again, we're talking about this chronic pain environment in low backs because we had to address this because our interventions need to consider that 30% of our listening population who have had some type of pain in their lifetime are going to be dealing with this. And this could be affecting their training. This could be, how many clients have we had come in and they were told you're never to lift more than 10 pounds.
Oh gosh,
you know?
yeah.
It's just ridiculous. You know, you can't live life that way.
Yeah.
Right, you can't live life. If your body cannot function at a level higher than that, then your body is basically useless. You've limited your body's natural genetic ability, and really primal biological function has been violated.
Right,
and that doesn't make sense.
Millions of years of evolution have prepared you to be more than that.
Right, and you're not. And you're really not that because you believe that you're something that you're not.
Yeah.
And that's that chronic pain perspective. The identified patient, like you said, you've catastrophized your situation. You have identified with that, and that's who you've become now. But the other thing there is that your body was designed to have this maximum genetic potential, and that's our goal. Our goal is to get you to that maximum genetic potential and have you be able to do everything that you need to do.
Yeah, absolutely. Well, I think that is a pretty good treatment of the subject. There's a lot to read on this. We're going to link it to a paper that kind of walks through all of these things we talked about, walks through those 4 elements of the chronic pain loop, as well as some interventions and how they have been proven in the literature to be effective.
Yeah.
And then next episode, we're going to talk about interventions and how you treat patients that come in with chronic back pain and how we treat.
We're going to get to the good stuff.
Yeah, we're going to get to the good stuff. So
yeah, I mean, I'm excited about the third. We might break this out into 2 separate episodes, but more rehab oriented if you're dealing with an active pain problem right now, and then one more training oriented. But they're very similar approaches. But I'm excited about that because that's the solution to the problem. We have to first of all understand, and that's why we've done it in this manner. Number one, what is the trunk? What is the back? What are the elements of that area? Number two, what do a lot of people experience when it comes to low back pain and chronic low back pain, and how does that influence what we do? And then number three, okay, what are we going to do about it? We're not just going to outline it in detail. What are we going to do about it? Yeah. And that's coming up in our next episode when we talk about, like you said, interventions and training programs. So let's take us out, man.
Yeah, I'm looking forward to that. Well, thanks again for joining us at 40Fit Radio. Go ahead and go to Instagram. Check us out at 40Fit Radio. Go to Facebook, the 40Fit Masters Community, and tell us about your experiences with chronic back pain. Tell us about how you have managed to treat it, rehab it, or maybe you're dealing with it right now and you're not quite sure what to do. Send Coach D a question.
Yeah, absolutely.
We'll help you out. We'll get you back on track and get your training going and help you live a better life.
This would be good to do what do they call it, a webinar? This would be a good one to do a webinar on low back pain and training. And I might just open a can of worms there. But also go to 40fit.com.
Yep, go to 40fit.com. As we link more of these research papers and the literature that we're citing in the show notes, we're also building a library of references on 40fit.com. So you can go there, check out all of the research that we're referencing, and read further if you want to.
Excellent.
Well, thanks again for joining us. We'll see you next week.
Thanks for joining the 40Fit Nation.